Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
In September of 2015, while she was attending college, Stephanie Bennett was suffering from nausea and diarrhea, and it hung around for weeks. She was diagnosed with a nasty infection of the bowel called Clostridium difficile, C-diff for short. Now, they tried to treat the C-diff infection with antibiotics, but it didn't work.
As a last resort, Stephanie sought help at Mayo Clinic. What finally cured her, believe it or not, fecal microbiota transplant, sometimes referred to as a stool transplant. Here to share her story and explain fecal transplant are the patient, Stephanie Bennett, and gastroenterologist, Dr. Sahil Khanna. Welcome, both of you, to the program.
Thank you for having us.
Thanks for having us.
Stephanie, how do you feel?
Much better now. Whole new person after the procedure.
Really?
Yes.
And, were you sort of amazed at the fact that, first of all, you got sick, and number two, that it hung on so long?
Yeah, I remember the day that I first started feeling symptoms. I just woke up, it was a Sunday, and I was like, I don't feel very good. And then I just started puking everywhere.
Really?
Yeah, it was, and that just lasted for way too long, and I was like, this is like very weird. Then when I went,
So this went on for days?
Oh, days, yeah. Weeks, because it ended up going from September is when I first started feeling symptoms, and then I officially got the procedure done in March.
Oh my gosh.
Yeah, so that whole time I was losing a significant amount of weight because I was just getting sick all the time. I had very bad, constant diarrhea, it's just not
No,
very
That's
pretty.
not good for a college
fun.
student.
No, yeah, and especially being at school, it was a very stressful time. I have to commend my roommates for really helping me out because I was in bed for quite a long time, and they would come and bring me Gatorade and water to keep me hydrated because everything was going in one way and straight out the other.
And so that started in September. And did you start antibiotics pretty quickly, or when did the antibiotic treatment start?
Did you go to the health center there, or did you wait until you got home and saw the
Yeah, I'm one of those kids that I'm just I don't like to go to the health center at my school, so I try my very best to wait until I can go to my normal doctor back in Chicago.
Okay.
So this was in September. I waited all the way until Thanksgiving break, which is quite a long time.
So
I
you're
know.
vomiting and diarrhea from September to Thanksgiving.
Yes, my mom was not very pleased that I waited that
Stephanie.
long.
Were you going to class?
Yes, and I was going to class, which is not the best thing. It was poor choices on myself.
I mean,
but
It's
you
all
were a
hindsight.
student, yeah.
Let's just let it go. She's fine now. Okay, so you started antibiotics at Thanksgiving time.
Thanksgiving break was when I went home and I did a stool sample test, and then it was the day after Thanksgiving that my doctor called me and said that you tested positive for C. diff. We need to get you on an antibiotic right away. So I did the first round of antibiotics, which was a 10-day pill named, I completely forgot the name.
You took vancomycin?
Yeah, okay.
Which is a pretty high-powered antibiotic.
Yes.
Vancomycin. You were taking it by mouth?
Yes. Oh, actually, I started off with Flagyl. So, and
And that's an antifungal, right?
It's anti-anaerobic, so it's for anaerobes, and it is the first-line therapy for C. diff. Not FDA approved, but what we use for first line. More data has shown that it may not be as effective as vancomycin even for mild to moderate cases, so it's falling out of favor right now.
Okay. So the vancomycin, you were taking IV, or?
No, everything was by mouth.
Okay.
So I did the 10-day Flagyl, which was, my body did not react very well to it. That was actually the lowest point of me having C. diff. I could not get out of bed that whole time because it was...
Are you still going to school at this point, or had
yes,
you? Oh
still
my
going
gosh.
to school at this point.
All right, keep going.
And then, so this now brought us to winter break, and I went home, got another stool sample test, came back positive. Then we moved to vancomycin, which is the second round, like Dr. Khanna said, another round of antibiotics. Did that, did another stool sample test, came back positive, did another round of vancomycin, still came back positive after that, and that's when my doctor was like, okay, we need to get you up to Mayo, and I was fortunate enough to be hooked up with Dr. Khanna.
Your new BFF.
Yes, who saved my life. It was night and day after the procedure.
Well, that is sort of strange. Did the infectious disease doctor say, I can't believe this, or this is fairly common that people we can't cure people with the antibiotics you've had, or what did he tell you?
Well, I learned so much when I came up here. So when I first kind of figured out like what C. diff was, actually like research on my own, I like this is like super contagious and things like that. And I thought it was more rare, but coming up here, Dr. Khanna taught me that it isn't as rare as you can imagine. I believe you said that almost like every day people can come in contact with this bacteria, but one's body can kind of just like fight it off, where mine for some reason did not.
For whatever reason, huh?
Yeah.
You have no idea where you picked it up?
No, the only idea is that I was in a hospital a couple weeks before that I started feeling symptoms, but we still couldn't pinpoint the time that where I actually picked it up.
Is that the usual case, Dr. Khanna, that there's really no way of knowing where you contract the C. diff?
That's true. So just putting everything into perspective, we see about 450,000 C. diff infections in this country every year.
Wow. Half a million.
About 500,000, that's the estimates. And it was previously thought that C. diff only affects the elderly who are in the hospital and who have received antibiotics. Now, Stephanie's the exact opposite. It's a young person who has not received antibiotics because of something else before C. diff started and was not hospitalized. So we're seeing C. diff more and more out in the community. Studies have shown that it's in the walls of meat processing plants, water sources, food sources, another person's hand, public restrooms. It's been isolated from everywhere. We're also seeing more and more young people who've not been exposed to antibiotics who get C. diff. Study done from Olmsted County, published a couple of years ago, demonstrated that 40% of C. diff actually happens outside the hospital, and of those, 20% have not received antibiotics. So bring us to a point that if you have someone like Stephanie who has unexplained diarrhea and other symptoms, C. diff should be kept in mind. It doesn't only happen to the elderly who are in the hospital. We're now seeing more and more of this nasty bug outside the hospital.
Do the antibiotics usually take care of the C. diff, or is that becoming that doesn't work at all?
So the expected rate of recurrent C. diff after a first round of antibiotics is about 20%, because these antibiotics which are used to treat C. diff actually kill the normal or the healthy microflora in addition. After 2 episodes...
The microflora, the normal healthy bacteria.
The normal healthy bacteria are also killed. In your usual state, you probably have anywhere between 500 and 1,000 different kinds of bacteria.
And you need those guys. You need those guys, that healthy bacteria.
You absolutely need those guys because they help colonization resistance all the time. But after a second episode of C. diff, the risk goes up to 40%, and after a third episode, it goes to 60%. So that's where your odds of getting it back over and over again, and people getting sicker every time when they get it, just keep on increasing.
All right, Dr. Khanna, Stephanie said you saved her life. So she finally came to Mayo in 2016. Is that right? Yes. Or beginning of this year. What did you do that saved her life?
So I'd say that we did something called a stool transplant or fecal transplant to help Stephanie alleviate her symptoms. Because if C. diff is untreated, it can keep making people miserable over and over again. Of the 450,000 people who get C. diff, the rate of mortality is about 29,000 odd people die from C. diff every year. So a lot of people die. Most don't, but a lot of people die. What we did for Stephanie was to correct the root cause of this problem. The root cause of this problem is not having enough good bacteria in your colon to fight against the C. diff. These medicines that are used for C. diff actually just kill the vegetative forms and not the spore form of C. diff, which actually tends to live in the body, and it's left on the body's own ability to fight against it. So what we did for Stephanie was to take stool from a healthy person or a stool donor. Like there are blood donors, we have stool donors who donate stool, and we were able to do a colonoscopy and implant that stool into Stephanie's colon to get rid of this infection.
Incredible story. Ms. Stephanie Bennett, now you mentioned that you were in the hospital. Are you a nursing student?
No, I actually, to clarify that, I'm a communications major, so I was doing a project that took place in a hospital where I was there about 6-7 times. So that was the only type, but that was like weeks before, like maybe a month before I even started feeling symptoms. So that's the only possible, maybe likely scenario that I picked it up there. But again, we don't know for sure.
It's always a good idea to stay out of the hospital if you can. All right, Stephanie Bennett and Dr. Sahil Khanna, we're talking about fecal transplants. We'll be back with a lot more and hear how they work and why they work when we come back after a short break.
We're going to find out, myth or matter of fact, anyone can be a stool donor, myth or matter of fact. You're listening to Mayo Clinic Radio on the Mayo Clinic News Network.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
We are with Dr. Sahil Khanna and Ms. Stephanie Bennett. She is a victim of a fairly common bacteria known as C. difficile. She tried antibiotic treatment and it wasn't successful. Her doctor in Chicago referred her to the Mayo Clinic, where she ended up seeing Dr. Khanna. And Dr. Khanna was just explaining to us why and how, or why he used a fecal transplant to cure her.
And so in order to have that stool to use for that transplant, you
Somebody's
need to have a
gotta give it,
donor.
yeah.
And so that brings us to myth or matter of fact. Anyone can be a stool donor. Is that a myth or is that a fact, Dr. Khanna?
I would say that's a myth. Not everyone can be a stool donor. Our understanding of the gut microbiome has increased over the last 5 years or so. We've known that a lot of diseases are associated with alterations in the gut microbiome. Common diseases like being overweight or obesity, diabetes, some neuropsychiatric illnesses, lots of GI illnesses like irritable bowel syndrome, inflammatory bowel disease, and infections like C. diff are all associated with alterations in the gut microbiome. We don't understand the cause and the effect equation here, but what we do understand is that people who need to be stool donors in today's world need to be free of all these common ailments. So somebody who has to be a stool donor actually has to be a young person, has to not have any of these common ailments or be at risk of any of these common ailments that I just mentioned. And then also they have to pass screening tests, so they should not be carrying any bacteria in their colon, which could be pathogenic. So we screen them for about 20 different kinds of bacterial infections in their colon. And then we also screen them for other communicable diseases like HIV, hepatitis, and syphilis. In addition, we screen them for a detailed health history and a travel history. So if you look at all these exclusion criteria, a vast majority of our population actually would not qualify to be a stool donor. A study done out of MIT demonstrated that less than 2.5% of everybody who applied to be a stool donor at a stool bank that has been set up in Boston were qualified to be stool donors.
A stool bank. Is this a paying position? I mean, do you have people who obviously want to do this, but do you get paid for it, I assume?
So the stool bank in Boston, in Cambridge, Massachusetts, actually does pay. We initially started with a volunteer stool donation program, but after recruiting the same donors for a couple of years, we have a little bit of an incentive that we pay them for every donation.
Stephanie, when Dr. Khanna said, here's what we're going to do, a stool transplant, a fecal transplant, did you say, I'm sorry, what again?
That's exactly what I said.
Why don't you just say, take this pill?
I thought he was joking at first. I wouldn't even fathom that this was a thing, but then the more you think about it, you realize how simple the procedure, not the procedure, but the idea is. You're taking someone's healthy stool and you're putting in somebody's unhealthy stool to kill all that bacteria. It's genius when you think about it.
And how did it work for you?
It worked perfectly, yeah. But again, when he first told me that, I thought it was like, oh, that's
You're
a real
crazy,
thing. Yeah,
man.
well,
Yeah.
my brother was like, he called me right away. He's like, can I be the stool donor? I can hold that over your head for the whole
No
time.
brothers.
And I was like, no.
No brothers allowed.
No.
So how do you do the procedure? Yeah.
So for Stephanie, we used an anonymous donor. So we've got our own stool donor bank here where we are able to take donor stool, process it in the lab, and have it frozen for our patients. We took an anonymous donor. Stephanie underwent a colonoscopy after a preparation for a colonoscopy. And we instilled the stool into the cecum. That's the last part of the large intestine, where the small and the large intestine connect with each other. We take for every patient, about 50 grams or a little less than 2 ounces of stool, and we dilute it in about 8 ounces of salt water or saline. And we put all that stool in there, and then we quickly come out of the colon, leaving that stool back in there.
Now, does it have to be fresh? I mean, are you able to preserve someone's stool for a certain period of time before you put it in?
Yes, so in the past we used to use fresh stools, but that was a nightmare if a donor is not able to produce stool on that day or forgets. So we were able to, at Mayo Clinic, establish an anaerobic chamber facility. So we are now able to process stool anaerobically. Most of the good bacteria are anaerobes, so they die on exposure to oxygen. And then we are able to store it in our freezer. Studies have shown that it may be viable for up to 6 months. With the demand that we have, we never have to store stool for that long. We usually keep a running batch at hand.
Stephanie, how long did it take before you could notice that you were feeling better?
Probably 3 days. Yeah, on that day 3, which he said it's common around that 3 days to a week, if I remember correctly. It was I noticed the second I went to the bathroom, and your stool looks different. You feel better. You don't wake up nauseous. Because I can't tell you, waking up when I had C. diff was one of the worst things. I would lay in bed, and I just knew the day was going to be miserable because I just already felt like I needed to throw up. And when day 3 or 4 came around and I didn't have that feeling, I was like, it worked. I was so excited.
Dr. Khanna, is this only used for C. diff, or are there going to be other applications? Because if it is so simple, it would be great if there was other ways that this could help people.
Yes, so for now it works for C. diff, works more than 90% of the times. There are other diseases that are being studied and under investigation. There are trials going on for GI diseases like inflammatory bowel disease, ulcerative colitis, or Crohn's disease. There's certain trials going on for diabetes. There are trials going for other rare diseases like primary sclerosing cholangitis. So a lot of that is at the clinical trial design, and with all the diseases that are associated with alterations in the gut microbiome-based therapies probably will become an adjunct to known therapies. Probably won't replace everything, but probably will become an adjunct to known medical therapies.
So you call it a simple procedure, and I guess in a way it is, but I mean, you have to, you said colonoscopy, so you take what we call the black snake, and all the way up, all the way over, and all the way back down to the very beginning of the colon. And that's where you insert the material, the stool.
Yes. So we're doing it with a colonoscopy right now. That's clinically done. There are going to be other delivery modalities that are being tested, including pill-based delivery modalities and enema-based delivery modalities, which are in clinical trials right now. So more is going to happen in this field in the near future.
So you can just take a pill?
Could probably just take a pill in the future.
Is this covered by insurance?
Colonoscopy.
Yeah, big way. Is this covered by insurance?
Yes, it is covered mostly by insurance. Sometimes we need to do prior authorization or pre-approvals, but cost model analysis have actually shown that with the cost of the medicines used to treat C. diff and the cost of work days that are lost because of C. diff, it actually is more cost effective than the pills itself.
We're trying to cut back on the number of antibiotics that we give to patients in the general population. Is a stool transplant going to become the first idea when someone is diagnosed with C. diff?
Absolutely. That's going to be a thing of the future. So there are going to be some trials that are going to be looking at that right now. I think what we need to realize is that we don't understand the long-term adverse events of fecal transplant. So it's not done as the first line at this time, but as we have more understanding of long-term adverse events and more data regarding efficacy for a first infection, it's probably going to become first line.
Stephanie, you've become the poster girl for fecal transplant. How do you feel
here.
about that?
It's very exciting.
You are on HBO, the HBO show about
I was
it.
lucky enough to be on HBO Vice. You came and filmed Dr. Khanna doing the procedure on me, and it's kind of cool being a little celebrity around Mayo, but I do give Dr. Khanna full credit for that. I emailed him and I was like, thank you so much I owe this all to you. So
I'm not sure I should ask this in front of Stephanie, but she, I'm sure, knows the answer. If you've had C. diff once, are you more likely than the general population to get it again?
Yes. You're more likely than the general population to get it again, but we've seen after fecal transplant that what I ask my patients is to avoid antibiotics. But after the fecal transplant, you should probably be like the general population as you're getting further away from the fecal transplant. The one reason that we see it comes back is with more antibiotic exposure due to another infection.
Dr. Shives, we need to do the Paul Harvey rest of the story here, because Stephanie took full advantage of her situation as being a patient and microphones and cameras in the room. And tell Dr. Shives what you do now.
I am a public affairs intern here at Mayo Clinic.
Oh,
yes,
good for you.
It worked perfectly.
You worked your way right in here.
I was very, very lucky.
Because of C. difficile. Yeah.
I like
One way or the other.
Yes.
Thanks. Stephanie Bennett and Dr. Sahil Khanna, thanks so much for being with us. Great story. And glad
you.
you're better, Stephanie.
Thank you
I'm
very
glad you're at
much.
Mayo.
Yes, love it here.
Thank you very much.